Good afternoon and welcome back. After lunch, hopefully everyone is now satiated, at least food-wise. We got a lot of work to do, so we're not yet completely there. But I am really excited about this next portion of our PACHA meeting. We are going to be expertly led through a conversation of some of the baddest women in the HIV response. You hear me? Ending the HIV epidemic in Texas, but addressing the needs of Black and Latina cisgender women in efforts to increase PrEP access and utilization, the million-dollar question in the movement of today. And so this panel is going to be facilitated by PACHA member and Stigma and Disparities co-chair, Rania Copeland, and yes, and PACHA member Natalie Sanchez. And I forgot one housekeeping thing. If you want to do headshots, there will be a sheet floating around the table. So they are trying to coordinate that. So if you want a headshot, sign up on the sheet. And I will officially turn this floor and this panel over to Natalie and Rania.
Thank you guys so much. Thank you so much, Marlene. We are so honored to be able to moderate such an important conversation. We've had PrEP for more than a decade. And I think when I think about our response to HIV, PrEP for me is one of the biggest dreams deferred. And when EHE was announced in 2019, it was announced as a whole of society approach and effort. And I think that when we talk about whole of society, we need to talk about women because women are impacted by HIV. But we also know when we talk about women, when we engage women, that is the way we engage a whole of society. And so there's benefit because of who we are as individuals, but there's also benefit because of the ways that we shape movements and culture and community. I'm excited to have this conversation during Women's History Month. With these amazing change makers, and I feel excited to talk about it at this moment. For me, at least, I've been doing this work, I think we all have, for a long time. And I think as a woman who's done this work, that when we've done women work around HIV, it's always felt like something that we have to push forward, that we got to find a little bit of coins for, that we actually do as volunteerism. But I think in the past few years, for reasons we maybe don't have to discuss right now, we've seen an increase in focus when it comes to women in HIV, which is really exciting. I also think, though, the conversation that we've had around the wholeness of womanhood has been very, very beautiful. I've had the privilege to sit in a lot of spaces where we talk about Black womanhood, where we do advisory boards, advisory groups, and there's been the conversation around cis and trans women, and I think that we've come to some agreement that there's importance for us being in spaces together because we are women, and there's also importance for us to have spaces alone where we can talk, where we can speak specifically about the issues that relate to us as women. Sometimes that means that we're going to be doing double the funding. That means sometimes there's double the work because we have to have trans spaces, we have to have cis spaces as well. And I'm really excited to have this space. I'm talking about Black and Latina cis women, and look forward to the time when PACHA is going to have space specifically for Black and Latina trans women. And so ensuring that this is one part of a bigger piece of conversation is really exciting. So I want to hand it over to Natalie before we introduce our panelists.
Yeah. Hi, everyone. Thank you. Thank you. Yes, thank you to PACHA for putting women center stage today at our meeting. As Rania said, it's been 12 years since they've approved PrEP. Beginning stages of PrEP, beginning years, women have been excluded for conversations. Women have been excluded as a priority population. And then looking at the numbers, we have 6,200 new HIV diagnoses in cisgender women. That rate has remained stable. And what stable says is no progress, no prevention strategy, no efforts made in PrEP to reduce HIV infections in women. So today's conversation is very important, and I am so excited to be in this room and as part of this panel of amazing women. And so for us, I really want us to come out with what's that strategy for reducing new HIV infections in cisgender women.
Awesome. So we're going to start. We don't have slides. The panel said no. So we're excited to really have a dynamic conversation. And we want to start with introductions. So we want to give each of our panelists an opportunity to introduce themselves, their work when it comes to Black and Latina women and HIV, their thoughts on why PrEP for Black and Latina cis women is critical in our efforts to end the HIV epidemic. And we're going to start with Dr. Charlene Flash, the president and CEO of Avenue 360 Health and Wellness, who's going to also we're going to give her a little bit more time to just give us an overview of PrEP for cisgender women as well.
You just threw that in there at the end.
Mm-hmm.
Okay. Good afternoon, everyone. My name is Dr. Charlene Flash, and I am the president and CEO of Avenue 360 Health and Wellness. Thank you for your visit on yesterday. As you know, we are a 7-site health system providing high quality and caring services, promoting healthy people and communities with primary medical, dental, and behavioral health care. However, we also provide cradle to grave HIV care, treatment, testing, education. In terms of my own journey and story, I'm also an HIV researcher. It started actually during my fellowship. The IPREX trial had been completed and published, and I went and found Ken Mayer and said, why aren't you all doing research in women if 1 in 5 infections in the United States is happening in that population? Why did you publish a trial and it's just gay men, right? And so what's happening with the women? Little did I know that that was going to launch my research career as I looked at the acceptability of PrEP, even before that was a thing to research, but looking at the acceptability of PrEP and various delivery mechanisms among at-risk Black women. Went on to look at changes in risk behavior and perception and indicators of adherence, not just to treatment, but also to prevention elements, and recognizing that when you're thinking about cisgender women, one of the primary challenges is perception of risk, right? And so even women who could identify the risk factors would say, well, I understand how HIV is transmitted. And even women who recognized that they had a potentially at-risk and probably positive partner based on the lifestyle of the partner, even women who are actively using drugs. At that time, I was in Massachusetts where injection drug use was raging then. And so even women who could describe all of those things, when you then ask them if they were at risk, they didn't necessarily self-attribute risk. Right. And so just at a ground level, if we're going to move this forward, we need to address that and make sure that people, in a non-stigmatizing way, we recognize that this is a virus and the virus doesn't know what race, gender, color, how much money you make. Right. And so we have to flatten that field a bit so that any of us can see ourselves as potentially at risk. Because if we don't see ourselves potentially at risk, then we're not going to move forward. And so this means not just in our research and our science, we have different delivery mechanisms that are available elsewhere in the world that are not available in the United States. Women need options and choices, but also in, what is happening in terms of the commercials. I remember sitting at the table fighting for commercials about PrEP. I said, you have commercials about Viagra. But I want to make sure that the imagery that's shown, that we all see each other in the commercials. The commercials are very diverse, but do we see people who feel like it could just be, the 3rd grade teacher or the grocer, or people who just feel like regular people? Because those are who my patients are, these regular people, and that's an extra barrier for us to overcome when we're trying to figure out if they're at risk. So the thing that I prioritize is making sure that hard to reach, quote unquote, hard to reach populations are prioritized. I think that I'll share one of my favorite quotes. There's a book, it's called Their Eyes Were Watching God by Zora Neale Hurston. And in it, it says that the Black woman is the mule of the world, right? And so if we're going to end an epidemic and we don't prioritize those communities that are often pushed to the margins, we have no chance of ending the epidemic. What will actually happen is the mainstream community of the epidemic will have excellent and exquisite control. The funding will go away. And those of us that are in the South, those of women, trans individuals, et cetera, there won't be funding left to actually seek out and to care for people on the margins. So when I think about an overview of PrEP for cisgender women, it took us a little time to actually even make the leap that we should be researching this. And I can remember having those arguments about, well, it's so hard to figure out because the risk criteria aren't clear and we don't have a clear risk module, right? And so I remember sitting and saying, that's lazy thinking, right? We put a man on the moon. You can't figure out how to figure out what the sample size is to conduct a trial for us to investigate whether PrEP can work in women. And so we have an oral, we have an injectable, we should have a ring, we should have a topical, we should have an implantable. Why don't we have these things? How can it have been a decade? We have these delivery mechanisms available for other things, yet we're not putting the money into investigating them for those areas. The other thing is the conversation earlier about money going to the grassroots. The answer is going to come from people within the communities. And but these communities are often spaces where you say, well, they haven't received funding before, so we're not going to give them funding because they're going to waste it, right? So why isn't a portion of that funding capacity building for these entities from which the answers will come? I'm not going to take over and put those things, but that's the story. That's the story. And I'm excited to be amongst this amazing team of women.
Thank you, Dr. Flash. Next, we have Mandy Hill, Professor, Director of Population Health of the University of Texas Health Science Center.
Hello, everyone. That's exactly what I was going to say when I introduced myself. Well, I have had the privilege of being a prevention researcher prioritizing cisgender Black women and Black populations in general for upwards of 20 years now. And my passion and drive to do this work has not fainted. It has not weakened over time. And we still have a lot more work to do.
Thank you. Next, we have Dr. Marissa Robinson, Health Equity Specialist Lead for the Black Women's Initiative Co-Lead out of OIDP HHS. Woo!
So good afternoon, everybody. I wanted to give a little positionality. So I wanted to say hello, ladies, gentlemen, and siblings and family. My pronouns are she and her. I'm an African-American woman with blonde hair. I have a magenta and teal scarf on with a white shirt. I'm a lifelong learner. I'm a daughter, I'm a sister, I'm a friend, also a Zumba instructor. And I am a champion for health equity. And in the words of the great John Lewis, let's get into some good trouble. And I'm looking forward to the panel discussion today. Thank you.
Dr. Robinson didn't also tell us that she's also an amazing dancer. And if you need to learn the Tamia dance, she's got you.
That's right. All right. Next, we have Shatera Johnson, Chair of the Texas Black Women Network.
Hello. Good afternoon. My name is Shatera Johnson. I'm a licensed master social worker. I've been in the HIV field for about 15 years, and I've been the chair of the Texas Black Women's Health Initiative Houston team for 10 years. And over that 10 years, we have implemented strategies and capacity building around PrEP in Black women throughout the state of Texas, as well as in the Houston area. So I'm really excited about this panel discussion. I've been on panels with Dr. Flash and Dr. Hill before, and just really trying to figure out how to garner more access and utilization of PrEP in Black women. I do look at it as a opportunity to end HIV in Black women and also in all our populations, as it being another tool in the toolbox of HIV prevention. But there are some challenges around that when it comes to Black women. Thank you.
Thank you so much. Next, we have Andrea Jackson from HRSA.
Good afternoon, everyone. My name is Andrea Jackson, and I serve as Senior Advisor in the HIV/AIDS Bureau at the Health Resources and Services Administration. We administer the Ryan White HIV/AIDS program. I have been a long-standing public health champion for reducing health disparities among people who look like me and Black and Brown people in general, and I'm just really excited to be here today and to hear from you all and to learn from you all about ways that we can continue to expand services to reach those in need. Let's turn it back.
Thank you. Next, we have Ashley Cobb, Community Ambassador. Let's Stop HIV Together.
Hello. My name is Ashley Cobb. I am a sex educator by trade. I work with women's sexual health and HIV prevention. I am also on PrEP because I wanted to be able to walk it like I talk it. Like Dr. Flash said, women have a perception of risk, right? So my job is to help cisgendered Black women, even though you may not be HIV positive, you are all HIV possible, and that is my job.
Awesome. Next, we have Adriana Avila de Bello, Senior Program Manager for the Association of the Advancement of Mexican Americans.
Buenas tardes, bienvenidos a todos. I'm Adriana Avila de Bello. I currently work for the Association for the Advancement of Mexican Americans, also known as AMA. We're in Laredo and Houston, Texas, and the organization started off probably late 70s by a bunch of women and men that just saw a need to really get down and dirty, if you would, and making sure that they don't lose their kiddos to drugs and crime. And they put forth this organization that over the years has just grown tremendously. I myself have been in this field for about 29 years altogether, roughly, just a baby coming out of high school, working at the city of Houston, and started off in the legal department, found myself going into finance and administration, and found a little passion there in public health and doing some DIS work, right? But while I was in that field, I also recognized that there was so much mistrust, misguidance, and just people being misunderstood. And I think that our next generation needed better. So I took on this role. I started off as an outreach worker and got out on the streets and really just gave it all I had to really talk to people and educate, our next generation, and making sure that we don't do the same things over and make the same mistakes. So excited to be here with all of you today.
Joining us online, we have Vanita Ray, Executive Director of Black South Rising.
Hey, my people, I am so sorry I am not there. I had 3 things happening at one time, and in my new life, something has to give. So welcome to Houston, y'all, and I will see y'all tomorrow, though. Vanita Ray, pronouns she, her, ella. Been living with HIV, it'll be 21 years, April 2nd. Have been doing some of the work around building the leadership of folks living with HIV since 2014, and which led us to the end. We did an ending an epidemic plan before the other one came about, and we have done. They mentioned the strike force, all of this. When we couldn't get others to do that other work, we began building our community. We kept building our leadership. We kept building our infrastructure so that we could do the work that you're seeing us do now. I went on to become the co-executive director of the Positive Women's Network, and so helped start the strike force. So I'm so proud of all of that. And now, leading Black South Rising, along with some other things, serving on the board of trustees for AIDS United, which I'm really grateful for too. But Black South Rising, we're about building the political power of Black folks in the South as a way to reduce negative health outcomes and disparities. I'm more focused on systems and root causes and political empowerment, Operation Liberation, as a way to really get there. And I see PrEP as a tool that we need to use now. But at the end of the day, once she got PrEP, does she still have a job? Is she still being discriminated against? Is she still getting paid less than he is or they are? So in the Black community, I believe we need more than just one of these tools. We need some systems change and some power building. And so I'm happy to be here. We'll talk more, and a little nervous, even though I know all these ladies, but thank y'all.
Not nervous, you just feel the power.
You know how I could get, and wait, y'all see a tall, handsome young man that's taking pictures in that room? That's my grandson. And if y'all, that's Trey, y'all, that's my grandson. If y'all think I'm passionate about my community, don't mess with my family. So he good and embarrassing.
We'll watch him. We got it.
Okay. You're only about 6'5".
All right, and then the last, but definitely not the least, we have Dorinthia Williams, co-executive director of the Dandelions, Inc.
Hello, guys. So I ran into an individual that's in this room right now and asked what Dandelions Movement was. So Dandelions Movement is a organization that I co-owned with one of my twin flames. We opened up this organization. It's a For Us By Us movement, which is for individuals that are born positive or diagnosed at an early age. Also, we encompass to identify 10,000 plus dandelions global. Hopefully we can find every last dandelions that's here. So also I also work I want to say at Emory University School of Medicine. I've been working there for the last 5 years as a peer mentor for individuals that are pregnant and positive. So I'm here, y'all.
All right, thank you so much. Welcome. We're going to jump into the conversation. Our first question is for Dr. Hill and Adriana. Can you discuss the specific factors contributing to the increased need for PrEP among Black and Latina cisgender women?
Yes.
Well, it's like you said at the beginning of this session, that we see this persistence in new cases. Although a lot of work is being done in the prevention space, we still see inequities based on race and ethnicity. Between 2017 and 2021, Black women are still 10 times more likely than white women to contract HIV, and Latina women are 4 times more likely. So despite everything that's being done, the persistence of those health inequities across race is why the need remains.
So several specific factors that I believe contribute to the need, or the increased need for PrEP amongst Black and Latina cisgender women. I mean, the data demonstrated, it's been 2019 and nothing is happening. It really isn't. When we look at a national number, it doesn't change. And that's kind of sad. It's almost disappointing because there's no action behind it. We see the RFPs going out but we really don't see those organizations having the support that they really need to fulfill those obligations, those objectives that really need to happen. I think about, the attitudes towards safer sex practices, in communities. I think about relationship power dynamics, I think about the domestic and sexual abuse and that intimacy partner violence that women face today. And they've been facing it for years, decades. It doesn't change. And so that's part of it.
Dr. Robinson and Shatera, this next question is for you all. We know that social determinants of health impacts everything. But what social determinants of health do you think specifically impact access to use of PrEP amongst Black women?
Okay, so as Ashley stated, one of the first and foremost things is that everybody is HIV possible. So we need to start reframing how we even think about risk, what Dr. Flash was talking about earlier. And also, women are a diaspora. We are not a monolith. We come from all different walks of life. And as Tori Cooper said earlier today, no matter how you've gotten to your womanhood, you are still a woman. And so we need to think about each other in those aspects. And it's not going to be a one size fits all. And so when we're talking about social determinants of health, where we work, live, learn, play, and worship, those are all the factors that impact us from a social determinant of health context. But what are the structural determinants of health? So we're talking about governance, we're talking about policy, we're talking about the societal values and cultural values that impact our daily lives. And so when we're talking about access to PrEP and how that looks different across the diaspora, one of the other things we need to think about is one medication in the daily context of what women are dealing with. If you're a caregiver, if you're a mother, if you have unstable housing, or you're unstably housed, or you have issues with transportation, or where you're thinking about where your next meal is going to come from, I can 100% guarantee that taking a medication is not the first thing on your to-do list or your priority list. So we need to reframe what we're thinking and saying, and then thinking about our women of lived experience. We have an individual on this panel that is taking PrEP and walking it like we talk it, but those same conversations, we need to have individuals of lived experience at the center of what we're talking about, so we can unpack further what that looks like. Because again, because we aren't a monolith, we are going to have to address things from a geographic context, from an age context, and then from the spectrum of the diaspora.
Thank you, Dr. Robinson. When I think about social determinants of health, and this is something that I know Vanita Ray was heavily thinking about when we were working on the ending the HIV epidemic plan for Houston before funding came along. Social determinants of health for me are systems. So it's a housing system, it's an employment system, it's an education system, it's lack of food insecurity system. Those are different systems that are not, I'm not gonna say it's not aligned, but those are things that we need to think about when we're thinking about HIV prevention and HIV care, is how do we tap into and work with and partner with, on a federal level, on a state level, on a local level, those different systems. HUD has housing money, and working with employment agencies, working with the different educational systems, from elementary to high school, from higher education and college and post-grad institutions and things of that nature. Because if we don't look at those social determinants of health or structured systems, we're going to be unstable. And when we're unstable, we're unhealthy and unproductive. So how do the HIV workforce partner with these other systems to build a better system for women when it comes to accessing PrEP? Because I can tell you right now, in some of a lot of the conversations that I've been having with women, particularly Black women over the last 10 years, they're not thinking about PrEP. They're thinking about everything else outside of PrEP, or even their quote unquote risk of being exposed to HIV. So if we're not addressing some of those social determinants of health that really is their priorities in their life, we're never going to get to having a conversation about, how about you take a pill once a day to prevent HIV? How about you take some injectables every other month to prevent you from contracting HIV? That is not on the forefront. The other thing that I see in this social determinant of health system is the maintenance of PrEP, staying on PrEP, being PrEP adherent. Sometimes it's hard to take a vitamin every day, or birth control every day, let alone another medication to add to our medication that we have to take on a daily basis. So those are some of the things that we really have to think about, is those social determinants of health systems and structures, and how do we partner and work together collaboratively on all levels when it comes to the HIV prevention with PrEP in Black women and Latinas.
Yes, yes. So one of those systems is HRSA HAB. So sitting right next to you is Andrea Jackson. We're going to ask Andrea, what has Ryan White HIV/AIDS program done to provide culturally appropriate services for Black women with HIV?
Yeah.
I want to add a little something to that. I'll take the moderator. And if you have anything to say about how you think that relates to PrEP or it doesn't, we'd be interested to hear.
Yeah, sure. Well, thanks for that context because, as you all know, the Ryan White HIV/AIDS program is statutorily required to provide services to people with a HIV diagnosis. Although we do encourage our recipients to leverage the existing Ryan White HIV/AIDS program infrastructure in order to provide status-neutral whole person services, which may include some prevention activities. So I will say that within the Ryan White HIV/AIDS program, among Black women who are receiving medical care, we are happy to report that about 89% of Black women were virally suppressed, and similarly that 91% of Latina women were virally suppressed according to our 2022 client level data. So we are really grateful for that. But as it has already been alluded to, there are subpopulations within those groups that have lower rates, including women who have unstable housing, younger women between the ages of 20 and 24 years old, and women who acquired HIV through vertical transmission. And so I just wanted to share a couple of activities that are underway within the Ryan White HIV/AIDS program to address Black women specifically. In 2020, we convened a technical expert panel in order to look at some of the specific ways that Ryan White services can be tailored towards Black women, and that conversation was framed around Dr. Kimberly Crenshaw's theoretical framework around intersectionality, which raised a lot of points that were already sort of discussed around sort of no one size fits all, ways that we can continue to emphasize cultural humility and a welcoming environment for women, especially Black women with HIV. Ways that we can reduce stigma and change some of the perceptions around women with HIV. And so that discussion led us to fund the Ryan White Part F Special Projects of National Significance. We had an initiative called the Black Women's First Initiative that was funded between 2020 and 2024. And the aim of that particular initiative was to improve health outcomes for Black women with HIV within a culturally sensitive and responsive manner through the delivery of bundled interventions. And so there was a pairing of interventions around peer engagement, trauma-informed care, self-efficacy, behavioral health needs, you name it, in order to address the specific needs of Black women who were serving in those programs. And so there are resources that have been developed and are available on ryanwhite.HRSA.gov that point to how those bundled interventions were used to improve health outcomes among women with HIV.
That was great. Thank you so much. I am interested, I want to go to Vanita and Dorinthia and hear from you all around how you think PrEP fits into the world of women who are living with HIV.
Go ahead, Dee.
Yeah, absolutely. So this was a question that I kind of pondered on. I didn't know how to quite answer. I honestly think, I think the issue is that most organizations are looking for individuals that are HIV positive to present PrEP to individuals that are not HIV positive. And I noticed that a lot of the world that I fit in, which is a dandelion, a lot of this is not my world. So I don't know how to say it. So
I got you.
If we talked about tasks and U equals U, that would be easy for me to conversate around. But it would have been a bigger communication on. As I was pondering on this question a lot of individuals knowing about PrEP and PEP being exposed would have considered that one a day before they got exposure with their sexual partner. Even if the partner said that they was monogamous, we would have the chance to protect ourselves, knowing that it could have been a preventative method from contracting the virus. of course, I would took that prep too as well. But it's hard because we're associating prep with people that are HIV positive. How do I fit it in my world? I don't know. I can't say specifically as a dandelion. I have talked about PrEP, preventative method for other people. I have put it inside of my family. My family did not know what PrEP was. A lot of my clients do not know what PrEP is, even though they are diagnosed like literally a year, 6 months. Providers are not giving answers, or these questions are not asked. The right questions are not being asked. So yeah, like, unfortunately, me personally, if my mother did have PrEP, it wouldn't be no dandelion. But unfortunately, like, and then if 80s and 90s, of course, that wasn't mentioned, but here we are, 2024, PrEP is being mentioned in this room. But unfortunately, I didn't get that opportunity, nor did my mom get that opportunity. So, yeah.
Thank you.
Woo, D, I feel you. So the first thing I wrote here, it's different for me in the way I see this. How does it fit in my world? It doesn't always, it does, as I am an educator and a community leader, that I have a commitment to always, want to share information and get folks, informed. And I want equity, as Tori Cooper was talking about earlier, so that folks have access. But it's different for us, whereas my health comes first. So I'm not the canary that, if you equals you, really, do I have to talk to my partner about PrEP? I mean, these a whole bunch of issues. If I want to, we had the female condom, the regular condom, or PrEP, but then we've got you, which we knew in the community way before we got the CDC to agree with Prevention Access Campaign that the science was the science. Because our folks have been having babies for years when there was no talk about PrEP. So glad to see a new tool, but it doesn't always come up. But what I'd like, if it could come up, how come we're not wrapping an HIV? So I want to see PrEP taken out of the HIV arena and talked about as women's health, because as long as HIV is only focused on sex, it stays stigmatized. And so if PrEP is a part of women's woman treatment plan, why aren't we doing HIV tests when I do my well woman exam? Those are ways that we can be talking about PrEP in other ways, not talking about being at risk, but every woman is vulnerable, Black women in particular. Why PrEP is needed for Black women? You all talked about the data, but let's look behind the data. What about political determinants of health? You all were talking about that. Put us in leadership. We should be the decision makers. As long as this epidemic impacts 60% of all the women that it impacts are Black women, we should be getting funded more. Why is the HRSA only spins project, Black Women's First, ending? Our epidemic isn't over. So, status neutral approach now is really just what the clinic should have looked like before when we went in there, that everybody got what they needed. And you don't have to do it in a way now that doesn't include me or uses my infrastructure. So one of the things I think about PrEP now is, do I have to fight for my Ryan White infrastructure to only be used to treat Black women living with HIV, which it feels like we do now? When you say infrastructure, that's money, that's people, that's systems. If I'm seeing 6 people now and you're using my infrastructure now to add PrEP to it, you might be seeing 4 of us less. So what I don't like, we have to say them, or a program, for the speculated, the HIV possible versus the HIV positive, because we're already here, whether there's 1.2 million of us or whatever, we're already here. So we don't want to be fighting over our money and people using different language to talk about using our money for something else besides what it was legislated for. So it's different for us. We are focused on our health first, and then the benefit is that the community benefits. So we want everybody to come up, but we want also our services to be there, and we will use the tools we've been using, because babies were being born before and still are in our communities And, you know, PrEP seems to be out of our reach. So PrEP isn't the magic tool, but it damn sure would help our women have greater access to support that they need while we're in the road to liberation, because that's where we're going. We're not stopping at the PrEP table, only just a stop.
Thank you. Our next question is for Ashley. From a personal perspective, what was the experience of accessing PrEP, and what are some of the main barriers for accessing PrEP? And then following that, for Dr. Flash, from a research and healthcare system, what are the main barriers preventing Black and Latina cisgender women from accessing PrEP?
Okay, so I get this question a lot when I talk about PrEP. I feel like it's two reasons with the access. One, public awareness. A lot of women don't know PrEP is for them. Marketing campaigns are not marketed towards women, Black women. This is not. How can I get on something when I don't know it's for me? That's the first thing. Also, perception of risk. There's a campaign with V that talks about risk to reasons. So no one sees themselves as risky. Like no one wants to say I'm risky, right? Mm-hmm. But if you give me a reason why I should consider it, even if I know that PrEP exists, well, why do I need it? I'm married, even though being married is not a prevention method. But sometimes people's seem that, you know, okay, what is my reason for getting on this? Because I'm monogamous or whatever they come up with in their head. So giving women reasons to at least look into it, even if they know that it's available for them.
Thank you for that. And so the main barriers. So there are multiple levels of barriers. I would say that I'll start with patient barriers. And so you summarize that nicely about what our perception, what an individual self-perception is. But, you know, even as we think about spokespeople, sometimes we have to be careful about that. Because I wonder if it's when we engage peers to talk with someone who isn't just from the community as opposed to someone living with HIV, are we re-traumatizing them by talking about if I had gone back in my history and done something different, I wouldn't be where in the space that I am in. So when we think about these patient barriers, it's about how do we as women of color exist in this world? We were having an offline conversation about all the things that we carry, right? And so when you're carrying all of these things, women aren't getting their blood pressure checked. Women aren't doing breast cancer screenings. There are all of these things that aren't happening because in many of our communities, we are the backbone of the community and we're doing stuff for everybody else and we're not doing stuff for ourselves. I will speak from, I don't do things sometimes for myself, physician, leader of a health system, don't do things sometimes for my own self. And so when you add this additional thing that's preventive, it's again something you can't see that you don't already have, it gets deprioritized. Aside from that, there are physician barriers. You know, some of my research involved interviewing physicians and talking to them about HIV prevention, testing, why aren't you doing this? And they had personal barriers about asking people about their sexual history and felt as though, especially when there was the provider and the patient were from different races or social norms, they felt as though the patient was going to feel badly if they asked them and feel like they were being judged if they asked their sexual history. You ask the patient, that person's patient, ask them. They said, well, of course, they asked me about everything. They asked me what my poop looks like. Why wouldn't they ask me about my sexual history, right? And so it's a barrier that's created in the clinician mind. Clinicians are people too. I'm a clinician. Clinicians are, and you think, you know, I tell my clinicians when I'm trying to get them through this, I said, listen, y'all are the most repressed people in America. You waited like 12 years to get your first big person job. And so then you're talking to people who are out in the real world doing other things. And there are barriers there. You have to admit that to yourselves because you're not here to judge these people. You're here to offer them options. And you're not saying anything about someone by educating them and offering them options. One of the core things that's heartbreaking for me is it's 2024. We've been doing this for more than 10 years. And women get angry when I tell them about PrEP and they don't already know. They're like, what do you mean? That's made up. How can this thing exist and I don't know about it? What else are they keeping from me? That's real talk. The other piece is that there are some cultural norms about sexuality, and it goes at both extremes. I would say that, I'm in this dichotomous world where I care for people living with HIV and I do HIV prevention stuff, so I'm putting myself out of business in the same breath, right? And I'd say half of my patients contracted HIV in monogamous relationships, right? So they didn't think of themselves as risky. They were just experiencing their life. And there are, at least in the Black community, there are some social norms about sexuality that younger women, I have a sophomore in college young girl, and they're thinking about freedom, right? They're not thinking about risk. I hope that she's thinking about safety, but she's thinking about freedom. And why are you trying to put barriers around me and wrap me in, because I tell all the time, I said, you're too cute, girl. I'm wrapping you in latex. But that's now how they think of themselves. She's trying to reveal more and be free and express herself. That's real, right? And so we have to have those conversations and understand that the same messaging is not going to work for even within the same racial group. There are these different cultural and sexual norms that we have to address. Then there are structural and systemic barriers, and I'm going to stop my sermon in a minute. So these structural barriers. So for some reason, our health insurance system, especially in areas without Medicaid expansion, only cares about women for their ovaries, right? And so in Texas, as a woman, if I want to get access, if I'm an impoverished woman, I want to get access to Medicaid, I have to be pregnant or have been pregnant within the last year, right? There's a whole other life that has nothing to do with childbearing. It's an important part of life. I have 3 children. It's amazing, but that's not the only time people need care. And even if people can access patient assistance programs and things of that nature, it's not just the actual cost, it's the perceived cost, right? And so if the patient thinks, oh, that fancy thing is available, but I can't get that, how on earth am I going to afford that? I got to feed my kids, I have to pay my rent, I have to pay for 3 bus rides to get wherever. And so those structural elements about how we get care paid for and the perception of how care is paid for has to be addressed as well. And I love having this conversation in this room, but I still was the infectious disease provider saying, why are we even talking about PrEP in the infectious disease room, right? The specialists of prevention are primary care providers, right? They prevent diabetes, they prevent hypertension. And that's why I'm not in my infectious disease, I'm a faculty at Baylor, I didn't even mention it. Division of Infectious Disease is a wonderful thing. I'm over in my FQHC in the community because primary care is a space of prevention, and that's where conversations about PrEP need to happen, because it's about, they should learn about PrEP in the WIC office. They should learn about PrEP when you're a sex worker and you got picked up. They should be talking to you there in the justice system. They should be talking about PrEP in school. It should be out there, not in these specialized settings, because then you set up another systemic challenge of we're competing for resources, right? And so then you literally can watch people whose bread and butter is the Ryan White system. You can watch the blood pressure go up and the veins going like this when you start talking about PrEP to them, because they feel like you don't put your hands in their pockets. Right. But the same challenge that we have with identifying women who are HIV possible, as you so eloquently said, is the same challenge we have with resource allocation. Right. And so we're talking about in these specialized rooms instead of going out there into the general world, because that's where you're going to find those women. You're not going to be able to just look at them and say, oh, that one's going to get HIV. It's much more difficult than it is in some other communities.
Thank you so much for that, Dr. Flash. All the eloquence. I want to kind of keep on the same theme, and I want to open this up to anybody who wants to respond, maybe a couple folks. What are some of the capacity building programs that have been useful in your work with Black and Latina cis women in PrEP? Like, what capacity building program you're like, dang, that's it. That hit I know all the things now, and this was fantastic. I'll wait for the responses. But then the other piece of it is, what are the needs? What are the capacity building needs we have when it comes to getting PrEP to Black and Latina women? Anybody want to respond? Anybody been through a fire capacity building program about Black and Latina women in PrEP?
Okay, I do want to mention, so I can mention something here.
Okay.
Black AIDS Institute, 2019, I was in the ambassadorship program, and I noticed that they prepared us on how to present PrEP to our community. And that's what we're failing at, is that a lot of us don't know what PrEP is unless we be taught. So I think the Black AIDS Institute did prepare us in the preventative methods, even though it was via social media, because that's what everybody is right now. But however, they did prepare a lot of PrEP and PEP and TAS, all of that I didn't learn until I got into Black AIDS Institute. So, which I was already failed in my community if it wasn't for Black AIDS Institute just teaching us how to literally discuss it. Thank you. Discuss PrEP to our community. I probably would have never known.
Right there. Don't go over there and make my heart all warm.
Yeah,
that was the last time that I saw you. And I see our little Black women in PrEP stuff that we developed when I was at Black AIDS Institute. So yeah, that was an amazing time.
Yeah, I was going to say the same thing, Black AIDS Institute. And I was going back through my emails, like, we've done a lot of work around PrEP since it's been out. And back in 2016, they had a PrEP learning collaborative. They had the PrEP town halls. It was also a BTAN had started talking about Black BTAN. I can't remember the treatment. Yeah, thank you very much. They started having conversations about PrEP in our local communities as well, and that was very helpful. And we're very grateful for it, but it kind of stopped. And so now we're just getting information, and we're still trying to provide that public awareness, as Ashley was saying, but it's more so on our own. And where we were at in 2016 compared to almost 10 years later, it's a big difference. And so having some more capacity building about what's going on with PrEP right now, because back in 2016 we was crying out, hey, what about PrEP and Black women? And now we have it, but now we need more capacity building around that.
Thank you. All right, this next question is for Shatera and Adriana. In what ways can we address cultural sensitivities and myths surrounding PrEP in Black and Latina communities?
All right, so I think it starts all in an experience, right? Cultural sensitivity. From the moment that you walk into the clinic or engaging with another person and starting up these topics, not too long ago, we had a particular case. It was a heterosexual couple. The guy had been incarcerated for some time, came out of jail. He knew his status. His partner didn't know their status. We were out in the community. We engaged them, offered testing. She was tested negative. His test was preliminary. And he jumped out of his seat, acting surprised. And the female, of course, he played it off like, oh, I don't want to get, stuck by a needle. I'm scared of needles. I don't want to do that. And he just kind of fled the scene, if you would. Left his partner there to kind of, wonder what happened. And of course, as a provider, we can't really say much. The only thing that we can do on our end is really be sensitive at that moment. And I think it's always about case by case situation, recognizing that every person has an individualized situation, experience, and we have to be very non-judgmental and kind of cradle it, right? Nurture it. We followed up with her. We talked to her, see how she was. She still didn't know his status. This is a week later, she's still lost. And talking to her about like, okay, what you doing, how you doing, and playing it off, and what's your next steps, you're eligible for a lot of services. Let's talk about some of the options that you can, and really getting her to think about, what happened that moment, and kind of reflecting back. And I still today, she never knew his status. And, we come to a point in our lives as women, we want to find that loving, caring relationship. We know how to nurture. We know how to love unconditionally, right? We know that there's always a way. We're very resilient. But somehow or other, mistrust, the fear, the shame that other people have to kind of endure. I think that just kind of relates back to stigma and not being in a good place, to be open about what is going on at that moment, right? And so I go back to, cultural sensitivity. I mean, it's you got to go case by case. I mean, my culture, I think to myself, just alone in my family, good Lord, I have all kinds of mixed breeds. And, we're global. If you look at my, Portuguese, Polish, and so we come from different backgrounds. We marry into, we look beyond. And so, but at the end of the day, it's again, that unconditional love that we have for one another. And so I think we just have to find that mindset. We can't be angry with people for having emotions. We have to meet them sometimes where they're at and be supportive. Count our blessings, right? So that's mine in a nutshell.
I'll be quick. So when I was looking at this question, I was thinking about my Black people, right? Me and my surroundings and my social circle. We're very visual individuals, creative. So having marketing materials like the commercials is great. I mean, I think they have came a long way with the PrEP commercials, but not enough. Because just seeing a woman twirling in a dress on a commercial is not helpful, to be quite honest. And again, we still don't see ourselves in those PrEP commercials, okay? And it's just maybe a half a second, and then the rest of the commercial is the other populations, to be quite honest. And so when they say they've infused women in these PrEP commercials, I'm like, oh, okay, I see that cute dresses, but what else? The other thing is sexual health education is a cultural sensitivity that we have in Latina community and the Black community, and the fact that we don't communicate in our own homes about positive sexual health. I was really excited when earlier this morning I seen my childhood and teen PCP here. She's the medical director for Fort Bend County Health Department, Dr. Gail. And I was like, you know what? You were the first person to tell me about sexual health. She was like, when you start having sex, you better start using condoms. And she gave me my first condom. So having those conversations with, like Dr. Flash was saying, not necessarily infectious disease doctors, but our PCPs, where we go to every year, our OBGYNs, we go to these people every year, every other year. Why aren't they having, I literally have to bring it up to my doctor about PrEP, about taking an HIV test when I get my pap smear and all of those well woman and things of that nature. Why aren't the other physicians outside of this HIV world trained, educated on this. And I don't know if that has to start from the top or whatever. And I know it's a conversation we've been having for many, many years about talking to nurses, talking to physicians, and going to their associations and having these conversations. What is the HIV education when they're in school? So infusing that into sexual health education, but also in time with that is the medical mistrust that we have talked about over the last hour or so. When we think about reasonings why birth control came around, we know that birth control came around because they were trying to sterilize Black women. So that's a medical mistrust that we still have within our heads, as well as the Tuskegee Act and even the OBGYN procedures, the pap smear procedures was done on Black women. And so there's going to be medical mistrust in regards to taking PrEP, or even in regards to taking HIV meds for your treatment. So that's something that we really have to address. Cost is another issue. That's a myth about PrEP. I'm at the Thanksgiving table saying, hey, cousin, I know you doing stuff out there. You might want to get on PrEP. I ain't got $3,500 a month to pay for no PrEP. And so then I have to do this education of you can do these different programs. But then it's the issue of that's a lot to do to get on some medication. That's what I hear all the time. And then the vulnerability that I was looking at when it comes to understanding your health outcomes and understanding how to take care of yourself as a woman. As we've already stated, women have all of these other priorities. And how do you make HIV prevention, STI prevention a priority in our lives? And so I definitely think that those are some of the cultural sensitivities and myths around PrEP when it comes to Black women and Latina women. It's really something that we have to address when it comes to that medical mistrust, and then also that sexual health education from birth to as you grow. Because there's a conversation that you could be having with your children from birth to them growing, whether it's good touch, bad touch, your body parts, all the way to the actual sexual acts. There's conversations that we're not having in our families and in our communities that we need to have. And I know people say comprehensive education in the education system, but it starts at home. And we also have to educate parents, because what they can't teach their children anything that they don't know themselves. So how do we have that comprehensive sexual health education within the community-based, as well as in the education system?
Yeah, you went all the way there with all the things. And what you just said, coupled with the question around what capacity building programs do we have that are focused on Black women and PrEP, and the lack of responses we got, because I think there's not many that we can point to, maybe any that we can point to, shows this huge gap that we have to go from where we are to where we want to be, and the things that we need to get us there. I want to go to Dr. Hill, because this question is related to that. You're a researcher, you do all the science and smart people things. What are the research and implementation science needs of these communities? What are the gaps, and who is funding the work in an impactful way?
Great question. Tough act to follow over here. This is one of our community advisory board meetings, members on some of our HIV prevention PrEP work with cisgender Black women. This is a loaded question. I think that the primary need as it relates to research and implementation science is for researchers and for Black women, Latina women to be seen, to be valued, to be recognized, and to be prioritized. And we can see a lot of conversation has been had around systems and what needs to happen. But like someone told me, the system is working in the way that it was designed. So we see who is not being prioritized, right? Black and Latina women. Going between Latinx and Latino, all respect, right? And when we look at the system, and we're looking at health inequities more broadly, like Shatera was just saying, all of these barriers to access to health, it's intentional. So when we have systems and all these multi-level barriers to extend health equity, sexual health equity to Black and Latina women, the insurmountable barriers that we have to overcome oftentimes just makes you want to just sit back and do nothing. So, and some of these things that were mentioned, those central tenets to combat structural racism, to combat medical mistrust, to combat stigma. When I'm looking at us trying to write grants that will address research and address implementation science, it appears that our reviewers are that of who created the system in the way that it was intended. Yes, so I don't have an easy answer. I see more problems than solutions as it relates to that question. And the gaps in the way that funding works in an impactful way. Well, it's the same problems. So someone said earlier, it was Benita, I believe, with the political determinants of health.
Thank you. I was going to chime in on you because where's the political will? Who are the decision makers?
Yes.
That's the deal you're trying to get to. It's the decision makers. So who's funding those research priorities, right?
Exactly. And I think that's the only way we're going to be able to move the needle forward and get towards ending the HIV epidemic if we have those decision makers prioritizing research and implementation science to move the needle with HIV incidence, HIV prevalence with Black and Latinx cisgender women.
Thank you. All right, that leads us to our question for Vanita. If you can discuss the political environment and its impact on HIV medication access for Black and Latina cis women.
Oh my goodness. The political environment, I think I had made some notes on this, but I probably don't have to say much on the political environment. You all from the county, the city already identified it. You talked about our lack of money. We know in Washington, Black folks and LGBT folks are on the menu, right? This ain't new. So Black women and Latina women living at that intersection of race and gender and discrimination and all the inequities that come with that. We are the ones most vulnerable. We're not just at risk. We're vulnerable because of a system. And it's not getting better. When we saw the overturning of Roe, we've seen now, FDA being challenged and only around access to healthcare for women. Yeah. So we got people who don't even look like none of us talking about what the policies should be going forward. We got a Supreme Court that ain't on our side. It's a fear every day of what we're having to look with. And that's why the political, you can deal upstream or downstream. I'm more focused on this upstream where how we deal with getting out the vote, finding more folks like Vinton to elect to office, finding more women, trans and cis, to elect to higher office. How do we change decision makers? We could talk about wanting to fix a system and do little things out here, but until we get at the heart of that system, begin to build our army of leaders, even while, they didn't just get to overturning Roe 50 years later. There was a building and momentum and a strategy long-term that allowed that to happen. That's the same thing we have to be doing, building our ground game, building our grass tops, building our legislatures. If they're not going to do it, we've got to get them out of there. So the political, we're talking about this, but I don't see a real commitment. I see people talking lovely about Black women and brown women, but I don't see resources that follow that talk. I don't see program. I don't see us in the decision making. I see those of y'all around the table look like me, but I see you all still trying to answer to a hierarchy that don't look like you or me. Those decisions that are coming out. I see y'all, and I'm not trying to blame y'all. Last year at USCHA, they dedicated to Black women. When everybody went home, I guess we are no longer, the data must have changed. But no, it didn't. We're still here. And so you wined and dined us. Wined and dined us. But now what the fuck we're supposed to do? So, I just really, I really, you got to put more to just the words of Black women and PrEP. How about elevating Black women with a traditional image of womanhood in need of protection, and realize she's the mother of her community in the background. And if she gets up, everybody comes up. And so we've got to do more than talking, having panels, which I love. I want to affect some policies and some funding and those resources that need to be had by Marsha Jones in Dallas, running the AFIA Center, doing groundbreaking work. You know why? Because she's involving people in the community and she's building their leadership in other ways as well. So that ground building and infrastructure building, Dandelions starting their nonprofit, they need some funding. Do you know how many people they could reach? They told you they want to reach 10,000. Who's going to fund them? Who's going to help teach them? They could do it. Yep. So the political environment isn't there for us, but it don't mean it can't be, because if not, we wouldn't have no hope. We represent 50% of the population as women. Never mind, we won't elect a woman president, and there's no one to elect right now. But the reality is we can build political power. We can elevate Black women and Latina women. We can become those decision makers. And that's what we need to be fighting for, to really make changes. And so that we not just dealing with at the clinic door, can you get this or that day, because the decision whether they could get it was made years before in an office somewhere. So we can do it.
Yes. I think one of the many things I'm taking from this is that if we're talking about PrEP for Black and Latina women, we can't actually be talking just about PrEP. There has to be a much bigger conversation about who we are. I know our PACHA members are chomping at the bits to ask this amazing panel some questions. And so we had a list more, but I want to kind of end with one final question before we open it up to PACHA members for questions. And I would love to start with Dr. Robinson and then kind of go around and see if anybody has anything else to respond. But we're interested in what strategies have you seen that have been effective in increasing awareness and knowledge about PrEP among Black and Latina cisgender women?
Thank you. Can we just give a round of applause for what we have heard so far? I thank you for the question. And I want to say first and foremost that I am a two-time HBCU grad. I went to Spelman College undergrad, and I went to Emory for my master's, and I just received my doctorate from Morgan State University a few years ago. And I focused my dissertation on Black women's perception, cisgender Black women's perception of PrEP uptake. And so some of the costs, some of the barriers that we discussed today were cost, stigma, as well as side effects. And then some of the facilitators of that are sexual liberation, freedom, and just having a woman-centered understanding of being able to have control and autonomy over decisions. So it really starts with reshaping the dialogue and honest and open conversations. So when we're talking about from the Latina and the African-American community and Black perception, a lot of times we're not having these conversations. We're having them with girlfriends. We're talking about sneaky links. We're talking about being freaky with girlfriends and sex toys and all these things. But then when you get in front of your parents, oh my gosh, I don't know what sex is. I don't know where babies come from. But we know that those things are happening behind closed doors. So in a cultural lens, and from a cultural perspective, we have a lot more work to do at home. And I think that we've already discussed that. But normalizing these conversations and letting people know that pleasure is good, pleasure should be centered. It's okay if you like pleasure, and that should be okay. And ultimately, we need to be talking about whole person health. So what does that look like? It doesn't just start with a diagnosis. It doesn't just start with you being a woman or a man or a person of trans experience or non-gender conforming. It starts with a person, because we are all humans at the end of the day, and we are all people first. So when we center that and we understand that we are all HIV possible, and for our siblings, brothers, and sisters that are living with HIV, your stories and everyone around these tables are lived experiences, and we are experts in our own right. We need to embody that, and we need to uplift those same things and not just walk it like we talk it, like Ashley said, but continue to lift up those that are not at these tables to go outside of our normal HIV conferences and convenings and meetings and start to bring back our young people who have no no skin in the game, and our individuals that are aging also, because they have been left out of the discussion. And I know that we have a wonderful subcommittee that was just formed recently, but we need to be talking about the spectrum. So I will leave it there. Thank you.
Thank you. Anything else from the panel before we open it up for questions?
I would like to add something.
Please do.
Okay, so in regards to something that worked, we did a pilot randomized controlled trial that aimed to link cisgender Black women from an emergency department visit to an initial PrEP clinic visit. We partnered with Legacy Community Health and Allies in Hope. And we had one confirmed visit of all 40 women enrolled. Now, while that was technically a proof of concept, that one individual, her mother was HIV positive, her grandmother was HIV positive. So her internal motivation was that of no one else that we enrolled. Okay, so I think when I look at that study, and she actually went on to do more research, she is definitely the poster child for who I really want to engage in my research studies, because she had that internal motivation. However, when I look at that study and I think about the way a lot of the RFPs, PAs, grant announcements are shaped around PrEP initiation, when we go to a mental health therapist, they know that the process of behavior change is slow. It's rarely, and I would think impossible, that you would have an initial visit with a therapist and they say, next time you should be doing this behavior. We know that it's slow. The same applies when it comes to PrEP initiation. And our research subjects over the last year or so helped, in our community advisory board, helped us to prioritize implementation intentions. How do we get people to consider PrEP as an option and take it slow? People are not going to go from, I don't know anything about PrEP, to, okay, I'll take it next week. So I think that we have to reprioritize this behavior change process from being PrEP naive to being a PrEP user. And I would say that specifically with Black women based on my research, but I would assume that it's similar with Latina women.
Thank you. Anybody else? Go ahead.
I concur. I just want to say that you have to also add the factors in. A lot of times you have fear. There's a big emotional part, and you can't just easily change. I mean, we talked about it earlier. We're not talking about substance abuse or misuse or any of that. We got stages of change. That's right. We go through grief. Yeah. These are all changes that we're going to have to make, and these are intentional changes, and we have to process that. And it's not overnight. I'm sorry, it's just not. It doesn't happen that way. And so the reality to say that, we're going to have this number of women or people on PrEP by this date, it might not happen. I hate to bust y'all's bubble.
Dr. Flash?
Yeah, other things that work. I mean, when we worked on that Black AIDS Institute Learning Collaborative to do some workforce development, that worked, right? Some of those organizations, small grassroots organizations, went on to become some of the largest PrEP providers in the community. And it wasn't just talking to the physicians, right? Back when I was in medical school and we were still talking about mother-to-child transmission, we realized that if you take it out of the hand of the doctor and the nurse drives it when they come in labor with undetermined status, that you actually had much more uptake of testing in pregnant settings. And so in that, you weren't just talking to the clinicians, we were talking to the community health workers and to the nursing staff and the medical assistants. So when you go in and the medical assistant's given that syphilis shot and the doc hasn't said anything about PrEP, the medical assistant's like, hey, have you seen this brochure on the side about PrEP, right? And so having it integrate as part of the workforce development throughout the different layers, that does work. And social media works. That's how, people in this realm that we're talking about, that works. And so investment into health communication strategies and how to make that effective and have the right because it's the message matters and the spokesperson matters as well.
Yeah. I think the last time I was in Texas a lot was for a prep learning collaborative that we did with Black AIDS Institute. It was here, we were like every other month. And so, but it's exciting to see that those types of investments work. And a bit disheartening to see how some of it's dried up, and some of the opportunities I think that lies ahead. Dorinthia, close us out before we
yeah, absolutely. You stated something about providers, and I think that was a question that was supposed to be asked, is that how do we get this out? I think most people are looking at community members to be able to present PrEP to individuals, right? But we're forgetting that providers are not mentioning this to individuals that they feel like they'll pose the risk of transmission or obtaining HIV itself. So I think more providers should be mentioning this to us as Black women, and it's not enough research around that. First of all, pregnant women too as well. I noticed that a lot of pregnant women are becoming positive, and they do not understand what PrEP is. I literally just got off the call with a client that I recently just got, and she was like, I do not know what that is. That's a problem because the provider didn't provide that to you. But that's all I want to say.
Thank you guys so much. What an amazing panel that we've had. And I want to give an opportunity to not just PACHA, but to our federal partners who, in many cases, control some of the things that we're talking about, to ask some questions and make comments to our panelists. So let us know. Yes. Look for any questions? DeAndre, thank you.
Thank you to all of you ladies. I appreciate you so much. And I just want to first give a comment and say thank you to all of you ladies who have been here today, especially you too, Miss Vanita, someone who I've worked with before. And I just want to remind everybody in this room, how amazing Black women really are. Black women have been the saving grace in this country time and time again. We think about the politics and the political landscape of who has saved our country in Alabama. We've seen it in presidential races and so on and so forth. But I feel like we as a human body have still continued to do a disservice to Black women to provide help and equity to you all. I know that this panel was focused around PrEP and Black women, but maybe Ms. Vanita or someone here can speak to it. What can we do as far as healthcare goes for Black women living with HIV? How can we be more intentional to make sure that we are seeing an increase in Black women living with HIV reaching undetectable viral loads and undetectable status? What is needed from this body? What is needed to make those recommendations that you all need from us? And how can we just be more intentional about that and using our privilege, male privilege, which is a big thing, and in our spaces to make room for you all and your voices in other spaces as well?
So are you asking me?
I'm asking everybody, but I want to hear from you, Ms. Vanita.
Yeah, so, some of we need other folks advocating for us too. We represent a huge swath of the epidemic here. In the U.S., women represent a quarter of the epidemic, and then Black women represent 60% of that. So we need y'all talking. If those resources and those things are not proportional to that number, there's a problem, right? We need y'all to help us not have to fight over our Ryan White infrastructure that folks don't think is money or that's going to not take something away from us. We need others in the rooms when we're not there, remembering that have we thought about how this will impact Black women living with HIV? In Houston, we created another pillar called the quality of life pillar that we still got to do work around, because the recognition that maybe the EHE framework don't address Black women living with HIV or people living with HIV, since there's 4 pillars, and treatment is there. It could say ending the epidemic and ensuring the quality of care for those living with HIV. I mean, in the new, we see a policy shift happening at the federal level towards status neutral. We're happy about PrEP for all, but we see what we don't want to see is a loss of our resources away from those of us who are already here, not possible, but already happening. And Black women in there, if folks making decisions about us don't look like us, we need y'all start to help speak up and say something. Have you asked the Black women? We're not hard to reach. That's for sure. So those are some of the things I can think of right off. Always ask how, the question, well, we're going to do this, but what about Black women? Have we thought about, because we're going to ask about Black gay men. To me, the Black community is one house. And we could have different rooms, Black gay men, Black women, whatever they may be. But when one room come up, the whole house come up. So we want every room in that house to come up. And we know that when women come up, the whole house come up as well. So just don't forget us when you're in those rooms, and we might can get something over here, but don't forget about the women over there.
And thank you, Ms. Bonita. I appreciate that. And I'm sorry, my apologies to Ms. Natalie, Ms. Adriana. Can you guys speak to what we can do for the Latinx community and Latina women? And thank you to my colleagues for pointing that out, that I forgot that that was the title of this panel specifically, but I want to be intentional about asking the same questions to you all in your demographic specifically.
Thank you. I was going to save it for my closing remarks, but you just walked me right into it. I was going to say I've been involved in HIV for over 20 years. So when I look at new diagnosis and the age range, that 53% of new diagnoses are between the ages of 25 to 44. I've been in that age group my entire career. And not until today has something focused and centered around Latinas who are HIV possible and had a space for me. Not once in my career has there been a program that was focused on Latinas on HIV prevention that was funded. Now imagine if I spoke Spanish only, no programming at all. And so I think for us is the fact that there's nothing, again, if we're not prioritized, we're not receiving the funding and we're not receiving the programming. So whose responsibility is it to educate people who look like me or people who are from my community to know about HIV prevention, to know about PrEP? And so I think, again, I think to me, it was eye-opening to myself when I'm sitting here moderating a panel where it's a reflection of I am part of that demographic. And not until now is it time for me to say, my group is a priority and my group deserves this space.
Can I just add a little bit to that? I will just say, I think it's important for us to center Black women and put Black women in places where they can be in positions of leadership and make decisions about their care and how those resources are allocated. So within the Ryan White HIV/AIDS program, that looks like making sure that, women are represented on the planning councils and your community advisory boards and all those other spaces in which we have an opportunity to directly impact the quality and the types of care that is being delivered to people with HIV, so that we can make sure that those needs are met and addressed firsthand.
I would like to mention everything they said, but also include dandelions.
Got it. Adriana?
I totally agree with Natalia. If you can look around the table, I don't know, you can count how many Latinos or Latinas are at this table right now. And, there's multiple reasons maybe why people don't come forward. But I know that my mom was a really strong advocate, and she didn't sit quiet. And if she had to be loud about it, she would. So, I'm here and I'm present, and I'm not going away.
So I know I was quiet about that, but I do agree with being as a Black woman, and that is a dandelions. It's a lot of rooms that we're not in as of right now. So to be in this room full of people and being able to voice my opinion, I am greatly honored. And I feel like if it wasn't for Black women and Latino women and women in general, I just want to say, because this Women Month, and I'm a acknowledge every woman in this room, there wouldn't be no one. So I just want to make mention that dandelions need to be in this room. Black women, Black dandelion women needs to be in this room. Latina women that are dandelions needs to be in these rooms too as well. So yeah.
Guillermo?
I want to also add my gratitude to all of you. Benita, I love you. I'm happy that I will give you a hug and a kiss tomorrow. But I also want to bring the issue of language justice. Not only language justice, but also dialects. You know, it's a lot of women that depend of someone to facilitate, right? To get to know the resources. Because we're talking about a core piece of empower. If we empower women, we empower everybody, I would say. And I will bring also how powerful the image of a grandmother is. That I always told people, and I encourage all of us. I encourage all of us to, because, you know, I think about my grandmother. You know, my daddy was an orphan. I only met my grandmother from my mother's side. And I truly, the person that I am right now, if they will say, pick one person, it was my grandmother. You know, born in 1893, fatty animal, loved to drink like hell. And also, but she told me that you have to do it everything well. Don't do a half job, you know. Be proactive, you know. And people that know me and work with me, they know that I try to honor my grandmother, you know. And then I think with this panel and the power that you give me today, it brought back the memories of my abuelita, my grandmother. And finally, how powerful is the intergenerational spaces too? Because I love someone mentioned Marisa or Derintia about we need to, and this is the complexities, right? We need to talk about adolescents, you know, young adults, over 40, over 50. We cannot exclude anybody, you know. But I love that we have all the federal partners here, and the Texas, you know, obviously is the force in this space, and we honor Texas. That we will think, and hopefully this panel will trigger, you know, opportunities, or go back to the board, to the drawing board and say, wait a minute, we have been missing this. We have not been given this space. And definitely dandelions that you mentioned, they're in here, is our responsibility. I told people, I said, don't expect anybody to give a space. Each of us need to be mindful about allowing all of us to be in this space. And I know the panel is not about this, but also I want to honor Asian women, Native women, cisgender women, because it's either all of us, and they say, you know, it's not too much data about this, I don't care. But Asians need to be also in our minds. Native people, my God, you know, especially in this land, we need to honor them. And obviously, you know, people say to me, mention one of your cheros and mentors. I said, Deborah Fraser House, strong Black woman. She said to me, let's go. I'm not going to say right now what she said to me, but let's go after this person, you know, that don't want to open the door, you know, tough cookie, you know. She's my GPS, and like many of you are, but thank you for sharing, okay?
Thank you, Guillermo. Oh, you got it. There you go. Thank you so much. Thank you so much, wonderful panel, for all of your insight. What I wanted to ask today is, we know that there exists a lot of medical mistrust for Latino and Black women gaining access to any medical care. Specifically for PrEP, we know that not all PrEP medication is safe for consumption for cisgender women. Right? What can we do? And this is for anybody on the panel that would like to answer this. What initiatives do you think that we need to create as a nation to be more inclusive of Black and Latino women gaining access to PrEP medication? We need options for females.
You know, a part of that is that there's some subtleties to medical mistrust. Sometimes there's mistrust of the institution, but people trust their one provider, right? So we have to think about, and it differs in different demographics, because there was some research actually done in Houston looking at that in Harris Health System. And so what element is the medical mistrust happening? Is it the institution? Is it the pills, or is it the person? And make sure that our interventions are accurately targeting where that mistrust is happening. But you know, what we are doing in my own institution is being sure to intentionally hire from the communities that are impacted that we seek to serve. Because that helps to break down some of the barriers of distrust when the person is walking your walk and talking your walk and was in the grocery store with you last week and then they tell you something. Sometimes that bears much more weight than however many degrees you have behind your name saying that. And we are not being intentional enough about workforce development and development drawing from these communities that are highly impacted. There are people in these communities that are amazing advocates, but they're not getting opportunities. Their school systems are bereft. They're not getting any health education. They don't even know that's a job possibility. And God forbid you say you could be a doctor. They're like, you know, sometimes I walk into a room with a patient and they're like, oh my goodness, a Black woman doctor, that's crazy. Are you really the doctor, right? And so we don't even have the images for people to understand that those are possibilities for them. And so although those are long range, because it takes a long time to make a nurse or make a doctor or whatever, but we have to make those investments at the ground level in these communities for workforce development and education and modeling.
I agree with everything Dr. Flash just said. While we're developing the workforce, we need interventions for providers. So we're doing some work right now where we have interviewed providers who are prescribing eligible and asked about their experience with extending PrEP to cisgender Black women. And we've asked about their normative practices. And what we found, we've also done focus groups with Black women and learned of some of the challenges that they face with the healthcare system. And what we're seeing is medical mistrust at several levels. Sometimes it's with an individual, sometimes it's with that healthcare experience overall. One of our codes that was most striking to us was access to humane treatment. We can't wait to put that in the literature. We're working on it right now. Yes. What we found, because in our minds, the theoretical mind, we just need to bridge the connection between the provider and the patient. And what we found was actually more discouraging, where the providers are waiting for the patient to initiate the sexual health discussion. Yeah. Well, if the patient wants PrEP, then they need to ask for it. And on the side of the patient, well, if it's something that I need to have, then my provider should tell me about it. So the gap is much further than we realized. And so we have to do a lot of work in designing those interventions on both sides that take into consideration the culture of clinical practice and the culture of the lived experience of cisgender, or for other investigators, Latina women. So that's what we found. I just wanted to share that.
Thank you so much. I want to close us out with two last comments. We're going to have Carol, and then it's very fitting to have Dr. Robin Neblett Fanfare close us out, because, you know, first woman in the role, first Black woman in the role. We are so proud and excited to have. So we'll have Carol and then Dr. Fanfare go.
First, I want to really thank the panel for your shared and your very individual experiences and experiences too. One of the things that I heard throughout, though, is the lack of representation, and including in the PrEP commercials. I just want to highlight that. We hear that continuously in our work, too, that, you know, you might see that woman in the twirling dress, but that's, you know, halfway through and for a fleeting second, and really how to tailor adverts and messaging to women, and in particular, Black women. I do want to point out, especially for everyone in this room, that the OAR, the Office of AIDS Research, has a comment period open until 11:59 p.m. tomorrow night. So Google it. It's an opportunity for you to talk about what kind of research is needed, and that would include women-directed products like microbicides, for example. It could include having things like childcare development written into research protocols, et cetera, et cetera, et cetera. The questions are a little weird, but you can answer them however you see fit, right? It's more important to have your responses in there. So Google OAR, which is Office of AIDS Research at the NIH, and it's the opportunity to comment on their strategic plan for the next 5 years. 11:59 p.m. tomorrow night. And then finally, I just want to ask a question. Thank you, Dr. Flash, for pointing this out about the different levels of providers. And we think the focus has been on community folks or physicians. And there's a whole bunch of opportunities in between there. And it could be the medical assistant, it could be the registrar, it could be the LPN, the nurse, et cetera. All of those people who actually have more than 15 minutes with the person who's there for GYN care, or who's there for hypertension, or who's there for something outside, how do we develop that workforce? So thank you for starting that conversation. I'd like to hear more about that, is that we really need to expand our workforce outside of those two pillars, community and physician. What's all in between there?
Well, it has to be done intentionally. One of the things back in 2012, I established one of the first HIV prevention programs in the country that was outside of a clinical trial in Harris Health System at Thomas Street Health Center. And when I went to my then mentor and boss, Tom Giordano, who you talked with earlier, and said, I want us to do PrEP training to the entire staff, including the maintenance people, everyone. It's like, oh, Flash, you're so crazy and extra. But what I know, and even as a patient, you can get disenfranchised at the front door. You can get disenfranchised the way someone doesn't answer your phone call, or just decides not to refill your prescription, or not, whatever from that. And for things as sensitive as sexual health, you really need to have everybody on board and educate folks, even folks who think are not involved in the care team, because they all are. Those folks who answer the call, the front desk or patient access representative, whatever you call, you break your health system by having, sometimes I say, gosh, we pay the lowest amount to the person who actually holds your health system in their hand. Because if the patient can't get through, that person, the reception who answers the phone, they're never getting to the clinician. And we don't honor those folks enough to make sure they know what's going on. Do they know that we're doing something about HIV prevention? We want everybody to know, or breast cancer, or whatever it is. They have to be part of the team too, and we got to educate them so that they can be part of the solution.
Dr. Neblett Fanfare.
Great. Well, first of all, thank you for this incredible panel and for centering and being intentional about this conversation around cisgender Black women. I just wanted to bring up a few things from the CDC space and then end with something that I think is important to also acknowledge. You talked about so many things that we are passionate about at CDC. One is social marketing, right? Anytime we go out, we hear so much from Black women that they don't see themselves. So how incredible that we have something like #She'sWell that was created for and by cisgender Black women. And when we've done the evaluation, and it wasn't just for women, it was also for the provider piece, as you're saying. And as we've done the evaluation, have seen that it has led to an increase in PrEP awareness and PrEP uptake in cisgender Black women. So now we're thinking about how we can scale that up nationally. You talked about capacity building, and all of this I'm taking back to the crib, just so you know. You talked about capacity building. We have something called Sister to Sister. Once again, that was created for and by cisgender Black women to help have these conversations and help build capacity. The work that we're doing in clinician support tools, how can we empower providers so that they feel comfortable and confident having these conversations once a Black woman is able to come in and say, hey, tell me a little bit about PrEP. We do guidelines. I want to center Dr. Dawn K. Smith, a Black woman who created the first guidelines for PrEP, and how important it was in her advocacy that we always have women at the forefront of that conversation. The last guidelines that she was able to update in 2021 led to kind of removing this conversation around risk and ensuring that anyone who asked for PrEP was provided PrEP, and anyone who was sexually active was spoken to about PrEP. That came from Dr. Dawn K. Smith to ensure that we are centering these conversations and taking away all of these barriers. So the last thing I will say is I'm going to come to each and every one of you, some I already know, but to give you my email, the 1, 2, 3 top things that you want to see CDC do in capacity building, guidelines, implementation science, research, program, policy, all of that we do, and we're so committed, not just myself, but so many leaders back at CDC about this work in cisgender Black women. So please do use that email to let me know what you think those top priorities are for us to center in 2024. Last thing, I did want to mention the American Academy of HIV Medicine, in association with BEAV, recently announced the Dr. Dawn K. Smith HIV Prevention Clinical Fellowship, and this is specifically to fund 10 fellows who are non-infectious disease so we can continue to increase this incredible workforce to do this work.
Thank you so much. Thank you to Marlene, to Vincent, for giving us the privilege to have this conversation, this much needed conversation around Black and Latina women and the need for PrEP. Thank you for letting us moderate, and I'll hand it over to Natalie to close us out.
All right. Thank you. As she said, thank you guys so much for giving us the space. I think the important takeaway is that stable is not progress. What we heard from Dr. Fanfare is the commitment from CDC to invest in Black and Latina cisgender women so that we do see that reduction in HIV infections. We came up with so many different strategies which were talked about. You know, you mentioned capacity building. Vanita mentioned incorporation of PrEP into women's health overall, or women health. We also talked about cultural sexual health, which is very important in addressing Black and Latina women. And the other thing that we talked about was that primary care is a space for prevention and looking for those other partners that are critical for incorporating PrEP, which include women's spaces such as WIC, schools, OBGYN. And so we hope from, as a result of this conversation and panel, that we see some progress that is being made, and that we see a focus on cisgender women, that this is not just the only conversation around cisgender women, but that it's integrated into all of our conversations. So thank you so much.
Thank you.
Again, just wanted to say, so many times I had to sit on my hands during this conversation and not get up out of my chair. We saw you online get up, Vanita, and you really almost made me get up out of my chair. But how wonderful for you to really share, very frankly, very candidly, from your perspectives about our movement forward as it relates to cis women. And so I just wanted to say, we won't take a break. We're going to take a pause. Because we do need a hard beginning at 3 p.m. So if you can, govern yourselves accordingly. You can step out if you may. If you don't have to step out, that'd be helpful too. But I just wanted to take a moment to thank. We're going to have this afternoon pause with a snack refreshment that's provided by OraSure Technology. So we really want to thank them for their generous support. We have Mr. Rick Mendiola, Ahmed Al-Hafid. They are in the room. So thank them as you grab your coffee, cookie, etc., and come back and be ready for 3 o'clock.
Produced by the U.S. Department of Health and Human Services.